Mexico. Um, these sessions are held weekly on a Wednesday. The chat will be open for questions. If you have questions, please place them on the chat or raise your hand, and we will get to them. So today, we're going to start off with Mohammed Emily. So he's going to present on metastatic hepatocellular carcinoma, and this is data from a PhD study that he's doing. We are then going to have case presentations from Malini Barna, Brian Masoy, and myself. We'll see how many we get done. I think we'll at least get 2 done. If we have time, we'll do a 3rd one. All right, Mohammed, over to you.
Thank you. I'm just going to share my screen. And just let me know if it's projecting on.
Okay. Yes, we can see that.
Let me get started.
Perfect. Yeah, perfect.
Right. Good afternoon, everyone. My name is Dr. Mohammed Imamali, and I will be presenting our study titled The Spectrum and Outcome of Metastatic HCC in a South African Patient Cohort. This research was conducted at Groote Schuur Hospital and the University of Cape Town in collaboration with my esteemed co-authors. Today, I will be discussing on our recent publication in the HPV journal, providing an overview of our study and highlighting key findings. I will begin by outlining the background and rationale for our research, followed by a detailed explanation of our methodology. I will then present the results, discuss their clinical significance, and address the strengths and weaknesses of our study. Finally, I will conclude with the key takeaways and potential implications for future research. HCC is amongst the leading causes of cancer-related mortality worldwide, with a particularly aggressive disease course in sub-Saharan Africa, where it disproportionately affects younger individuals. The underlying etiology of HCC differs significantly between regions. In high-income countries, alcohol-related liver disease and chronic hepatitis C are predominant risk factors. In sub-Saharan Africa, chronic hepatitis B and HIV play a far more substantial role. Despite the high burden of HCC in sub-Saharan Africa, limited data exists regarding the patterns of metastatic spread and their implications on patient survival. Understanding these metastatic pathways is crucial for optimizing early detection and treatment strategies. However, in many resource-limited settings, HCC is often diagnosed at an advanced stage. Thus, metastatic disease is already present at the time of presentation. The lack of region-specific data and the need to better understand the clinical course of metastatic HCC in SSA motivated us to conduct this study. So going through the aims and objectives, our study aimed to characterize the metastatic burden of HCC in a South African cohort, identify risk factors associated with metastasis, and evaluate the survival impact of different metastatic patterns. We conducted a retrospective cohort study of patients diagnosed with HCC at Groote Schuur Hospital over a 33-year period. Data was extracted from an institutional registry, and we compared metastatic and non-metastatic patients using various statistical methods. Amongst the 676 patients in our study, 194 were diagnosed with metastatic disease at presentation. The most commonly affected sites of metastasis were the lungs, bones, peritoneum, and spine, reflecting the diverse patterns of disease dissemination observed in our cohort. A particularly striking finding was that over 80% of our patients with metastatic disease had already developed secondary spread at the time of their initial diagnosis, underscoring the late presentation and advanced disease stage commonly seen in our population. This trend highlights the critical need for earlier detection strategies, as patients often seek medical attention only when symptoms become severe, limiting treatment options and adversely affecting prognosis. Patients with metastases were significantly younger than non-metastatic patients, and chronic hepatitis infections and HIV were independently associated with an increased risk of metastasis. Additionally, AFP were markedly elevated in metastatic patients, reinforcing its role as a biomarker for advanced disease. As anticipated, patients with metastatic HCC demonstrated significantly worse overall survival compared to those without metastatic disease. Amongst the various metastatic sites, spinal involvement was associated with the most severe prognosis. To further assess the potential impact of systemic therapy on survival, we conducted a Kaplan-Meier analysis comparing the small subset of patients who received systemic treatment for their metastases. Notably, only 15 patients with metastatic disease received systemic therapy, highlighting the limited availability of treatment options in our setting. Among these, 12 patients received sorafenib through a donation program between 2010 and 2017, while the remaining 3 patients received doxorubicin. Despite the small sample size, our findings suggest that systemic therapy was associated with improved survival outcomes in metastatic HCC patients. This emphasizes the potential benefit of treatment even in a resource-limited environment. These findings underscore the urgent need for expanded access to systemic therapies, particularly in low-income countries. Our findings reinforce the aggressive nature of HCC in sub-Saharan Africa, where a significant proportion of patients present with metastasis at diagnosis. The strong association between HIV and hepatitis B suggests that chronic co-infections may contribute to disease progression and metastatic potential. Interestingly, our data show that survival outcomes vary depending on the site of metastasis, raising an important question. Would certain patients with limited metastatic disease benefit from more targeted therapeutic interventions? This concept is known as oligometastatic disease and is currently being explored in other malignancies where patients with a small number of metastases may still achieve improved outcomes with local or systemic therapy. Our findings suggest that further research into the subgroup within HCC is warranted. Our study provides valuable insights into the metastatic burden of HCC in sub-Saharan Africa. However, as a single-center study, referral bias may have influenced our results. Additionally, follow-up data was incomplete for some patients, and the lack of available systemic therapies in our setting limited comparisons with international cohorts. In conclusion, HCC in sub-Saharan Africa is highly aggressive, with a significant metastatic burden. Chronic hepatitis B and HIV are key risk factors. Our findings suggest the need for further research into oligometastatic disease and improved access to systemic therapies to enhance patient outcomes. And that's the end of my presentation. Thank you for your time.
Thank you very much. It's interesting data. Are there any questions or comments? I just want to see the chat. Yeah, so while you were chatting, I was thinking about the oligometastatic disease concept. I mean, I'm not sure if you looked at it. How many patients with how many patients just had isolated lung mets of the patients with lung mets?
So there were 83 in our cohort that just had isolated.
83. And do you have any idea how many of them would maybe have been potentially resectable or treatable?
So that's something that we're looking at in our next papers, to quantify how bad the lung mets were. And we're looking at tumor volumes to assess resectability and how much of that we could actually take out. Okay.
I mean, something that I remember when I started treating patients with HCC was you always worry because so many of them have ascites because of the portal hypertension that they may have peritoneal metastases, but yeah, your data showed that that's actually quite rare.
Yeah, so I think the major metastatic sites for us were the lung mets, and then followed by spine mets, and of which spine mets showed the worst or the poorest survival.
Okay, all right. Thank you very much. If there are no questions or comments, we'll move on to Dr. Barno, who's one of our fellows, who is going to show us a case.
I'll just share my presentation. Okay, can you see my screen?
Yes, we can.
Okay, thank you. So I'm going to start with this case presentation. So we recently had a 26-year-old female who came to us from Mitchell's Plain. She presented with about a month's history of right upper quadrant pain and worsening abdominal distension. She was also noted to be a newly diagnosed hepatitis B, with her surface antigen being positive. On examination, she had massive hepatomegaly, but was not clinically jaundiced. In terms of her blood, she was RBD negative with Belize of 10. Her tumor markers were normal in terms of the CA and CA99, but her AFP was quite high at 17,000, more than 17,000, and her Hep B viral load was 353. So this is what her scan looked like. So you can see quite massive hepatomegaly with diffuse lesions involving mostly the right side of the liver. There is some left-sided involvement of segment 4 as well, and extends down all the way. The portal vein looked still patent, and then she has some ascites as well, which made her Charles-Pugh B8. We look at the bony view of this. So there were no lung mets. I didn't show the lung videos. Sorry, I didn't have a good video of that. But if you just take a look at the vertebra here, around the thoracic area, here you start to see lytic lesions in the spine extending all the way from T8 to T11 with significant areas of lytic lesions. She was asymptomatic of this with no neurology, no complaints of back pain either. So if we just look at spinal metastases in HCC, it's quite a rare finding. It occurs in about 1 to 7% of extrahepatic metastases. The pathophysiology is likely related to one of two major ways, the most common being hematogenous spread, either through the venous, through Baxen's venous plexuses, which communicate with the spinal veins, or directly from the portal vein to IVC to systematic spread. The other way is contiguous spread, which is a lot less common. These patients generally present with back pain, and that occurs in about 70% of cases. Pathological fractures are the second commonest, and then weakness due to myelopathy is another problem. So that's generally from this rapid tumor growth with surrounding edema and hemorrhage, which then compresses the vessels of the spine and results in the myelopathy. But inevitably, this is preceded by back pain before that happens. And then a smaller portion, 15%, will present with clinically significant hypercalcemia. Typically, these lesions are osteolytic and most commonly located in the thoracic and lumbar spine. The median occurrence is around 20 months from the diagnosis, with a median survival without treatment being 7 months. I should also mention that this is largely based on case reports, as there is no significant literature. The study which Mohammed has presented is probably the biggest cohort there is, which I haven't included in this. In terms of the treatment for spinal mets, there's also no good evidence. The three available options generally are surgery, radiation, and chemotherapy. And of these, combination therapy has shown to have the best results, with patients with surgery and radiation or adjuvant chemo having sort of a life expectancy of around 12 months, and those without adjuvant treatment or just chemotherapy alone being less than 6 months. The other important thing to remember is if they present with a neurological deficit, urgent treatment is quite essential, with glucocorticoids being a bridge to definitive treatment, that being either surgery or external beam radiation. And then the role of systematic therapy like sorafenib and sunitinib has been used in literature and case reports, it's mentioned, but not a lot of evidence for that either, and we don't currently have it available. So if we look at it for this patient who has asymptomatic spinal metastases, there is no great literature on whether that should be treated or not, but there are some case reports who use it as a measure to prevent further progression, especially if patients have vertebral body involvement, because they obviously at higher risk of getting pathological fractures and getting neurology or other symptoms and further progression thereof. Okay, thank you. Are there any questions?
Thanks, Melanie. Are there any questions? So I didn't get it. Did this patient get any treatment?
She ended up getting radiation, just a single dose of external beam radiation. Okay. And they said they would further just follow up and see if she does develop symptoms. They would consider further radiation for her.
Okay, and So she didn't have neurology?
She had no neurology, no back pain, no symptoms of it.
Okay. Yeah, I think the point that you made that you know, the it's urgent once there's neurological fallout, and it's one of the few times that I think you can get it. You should get an oncologist even out of bed or to work on a Saturday, is if a patient comes in with acute neurology due to spinal metastases, because if you intervene early with radiotherapy, you can get an improvement. Brian was going to do the next case. I think he is stuck in theatre. Is that still correct, mate?
Yeah, he's still in theatre.
Okay. Maybe you can just check if he's going to be done soon. But I
Sure.
will present my case then. Let me just share. Sorry, it's bigger. Sorry, guys. In the beginning. Can you see that?
Yes, we can.
Okay. So the case I'm going to present is a 54-year-old female who presented, who had been diagnosed with hepatitis C a few years ago. It's not actually too clear to me who managed her initially. I think it was discussed with our hepatologists, although they weren't the primary people taking care of her. The hepatitis C was treated and cleared, and that's one of the major advances in hepatology in the last 15 years or so, is that we can now eradicate hepatitis C. But we do know that once these patients have cirrhosis, the HCC risk does persist even after the hepatitis C is treated. The patient presented to another hospital in Cape Town in August last year due to right upper quadrant pain, and an ultrasound identified liver lesions, and that prompted some further investigations. So I'm just going to go through the CT scan that was done in. Both of these are the portal venous phase. I'm going to show the axial images, and then we'll go on to the coronal images. So you can see there's a lesion that looks a little bit washed out, quite a big lesion. Segment 7, extending down into segment 6. There's another lesion quite close to the gallbladder over here, segment 5. Of note, segment 4 and segment 2 and 3 look clear. There was also a prima vista MRI, which I'm not going to go through, but that showed no lesions on the lateral or in the left lateral segment or on segment 4. It's maybe not very obvious, but the liver surface is not completely smooth. There's some irregularity, in keeping with cirrhosis, and a bit of a chunky portal vein and a big spleen that you can see there. She did have a scope, and that didn't show any esophageal varices. If you follow the right portal vein, so let me show you that. So there's the left portal vein coming down. Here's the right portal vein. As you get into the more segmental branches, it does appear like there's tumor in vein, and that probably accounts for the big left side of the liver. I'm just going to show you on the coronal images, same scan, just different cuts. So you can see how the tumor is confined to the right side of the liver. So the patient then had had an MRI, as I mentioned, and initially it was really not a very good report. There was no, no mention of the lesions according to the LIRADS criteria. And I think I actually don't pay much attention to radiology reports if in patients with cirrhosis, if the LIRADS criteria are not used. So as we know, LIRADS, LIRADS 1 is almost definitely benign. LIRADS 2 is probably benign. LIRADS 4 is probably an HCC, and LIRAD 5 is definitely an HCC, and LIRADS 3 is sort of an intermediate area. And there's lots of reasons why you have nodules, and obviously in a cirrhotic liver, they can just be regenerating nodules that are showing up. They could be dysplastic nodules, but we're really only interested in treating them once they developed into an HCC. So this patient had lesion 1 was a LIRADS 5, and that lesion measured 7.5 centimeters in its maximum extent. Lesion 2, there were 2 LIRADS 5 lesions. So that lesion measured 3 centimeters in its maximal extent. So I'll go into the transplant criteria now, but according to the transplant criteria that we use, this patient was outside of criteria. And then there were 2 LIRADS 4 lesions in addition. So, we are reluctant to biopsy HCCs unless it's really going to change management. So we would sometimes do it in LIRAD 4 lesions, and sometimes to assess tumor biology. But in this patient, it's probably unnecessary at that stage to do a biopsy. So management is good. There's lots of different, as we know, lots of different criteria or staging systems for hepatocellular carcinoma. One of the ones that's commonly used for cirrhotic patients, mostly in the Western world, is the Barcelona Liver Clinic staging system. This is this is the updated version from 2022. It doesn't always work well in patients who come from Africa and Asia, where there's a high incidence of hepatitis B and non-cirrhotic patients. So our patient probably actually falls into this intermediate stage group. And one of the changes in this new, sorry, let me just go back, in the new Barcelona Liver Clinic staging system is that the intermediate stage group is divided into 3. So if you would consider using extended liver transplant criteria, you could consider transplantation. TACE is an option for patients with preserved portal flow and well-defined nodules. And if the patient's got very diffuse infiltrative disease, systemic therapy may be better. If you look at the role of resection in this, it's limited to patients without portal hypertension. That's the one thing. And patients with early stage disease, so single or less than 3 nodules. Obviously, these lesions were too big to ablate. So she was discussed with us about whether she would be a transplant candidate, but we felt that she was outside criteria initially, and suggested that she have a TACE. So I just want to talk a little bit more about the transplant criteria. So in South Africa, we use the UCSF criteria, the University of San Francisco criteria, which are 1 lesion that's less than or equal to 6.5 centimeters, and 3 lesions, up to 3 lesions, where the biggest one is smaller than 4.5, and the total diameter is less than 8. If you transplant within the UCSF criteria, your overall survival at 5 years will be about 75%. The Milan criteria is the one that's often talked about, and they have an overall survival, if you use that, of 85%. And then as you extend your survival, or as you extend your criteria, survival goes down, and that's what we refer to as the metro ticket concept. If Milan is quite restrictive, has a higher survival. As you go down, like towards UCSF, you're transplanting more patients, but you have a lower survival. So by being more liberal with your criteria, you have worse survival, which makes sense. One of the interesting things that's come available or come around now is the Toronto criteria, and that's basically if you're within Milan criteria, that's all well and good. If you're outside Milan criteria and you don't have extrahepatic disease and you don't have venous invasion, then the tumor gets biopsied, and provided it's not poorly differentiated, so if it's well differentiated or moderately differentiated, then you still get transplanted. And if you stick to those rules, even if you beyond the Milan criteria, your overall survival is 70%. So I think that is showing that this obsession about morphology and size of tumors is actually very, very crude. Size doesn't necessarily imply bad tumor biology. And size is a function of rate of growth and also the duration that the tumor's been there. So I think we can almost say that I think Milan criteria is going to become largely historical, and the morphological criteria are going to become a little bit historical, and we're going to start using biological criteria more and more. So if you look at this paper that was published in 2017, they look at various factors, risk factors, so things like microvascular invasion, poor differentiation, high AFP, positive FDG PET, early recurrence after local regional therapy. And if you have a limited number of these factors, or maybe only one, depending on your BCLC stage, you could still be transplanted with quite good survival. If you look at our data, which is slowly growing, and with us doing as we slowly, we probably do 1 or 2 transplants for this indication a year. Our 5-year survival is very good, and I think, well, of the patients we've transplanted so far, all have made it to 5 years or are still alive, and that suggests that our criteria are too strict, and that we should potentially be extending our criteria. So, as I said, this patient had a conventional TACE. It was done at a hospital that doesn't often do TACEs, and that was done in September. So she presented in August. She then had worsening right upper quadrant pain and some chest pain, which was maybe pleuritic, difficult to say for sure. So we look at her bloods. Her starting AFP, which was also a worrying factor, was close to 800. We would not transplant someone with an alpha-fetoprotein above 500. After the TACE, which was done in September, the alpha-fetoprotein had come down nicely. But she was not feeling well, and she came to see me on the 26th of November last year, and I repeated her bloods that day. You can see that the alpha-fetoprotein had started to go up, and we got a new CT scan. So this is now post-TACE. The TACE was done with lipidol, so it was a conventional TACE, not with drug-eluting beads. So you can see the lipidol, which is a contrast agent, in that big tumor, the larger one that was about 7 centimeters, and go down. The other lesions had not been TACed. So if you look here, this more central lesion in segment 5 had not been TACed. But also, you look here, you can see this little trail of contrast material going towards the hepatic vein in the vena cava. You can actually follow it into the vena cava with thrombus. So what had happened is the radiologist who did this had not realized that there was shunting, which is not unusual, from the hepatic artery to the hepatic vein. So you have these hepatic arterial venous shunts, and those need to be dealt with before you do a TACE, which they weren't. So now there was contrast material, and on this CT scan, there was also evidence of some pulmonary emboli. Also of note on the CT scan is there's now biliary duct dilatation. And if you look, here's the bile duct. If you can see that in the head of the pancreas, we're going to follow it up. And you can see there's material which we thought looked like tumor in the bile duct. And the hepatic vein thrombus is on the right, is still limited to the right hepatic vein. But of note, the left side of the liver has got bigger. So I'm going to show you on the coronal now. Sorry, struggling to control this. Sorry. Okay, I'm just going to go slowly again. Sorry. Right. It's sort of you can see contrast. You can see the tumor in the vein there, I think, a bit better. You can see the dilated duct quite nicely there, and you can see how that also looks like it's got material inside the duct. So I got a phone call. I saw on the 26th. This scan I think was done on about the 27th or 28th or 27th of November. I got a phone call from the radiologist who did this scan to say, listen, there's all these things going on. So I admitted her to hospital on the 27th. So if you just look at her blood results on the 28th and the 30th of November, you can see that she was becoming progressively more jaundiced. She also developed some melena. HB dropped a little bit. I scoped her, there were no varices. So we're now in a bit of a dilemma because of all of this that's going on. So let's want to go back. So I discussed it with my colleagues, Professor Jonas and some other people. You know, she was a child Pew A before she became jaundiced, and there was big hypertrophy of, well, a large amount of hypertrophy of the left side of the liver, and we felt that there really were no treatment options left to her, and that she was still potentially resectable, although it would be a fairly major undertaking to resect her right lobe of the liver, resect the bile duct, and do hepatic angiogenicity onto the left hepatic duct. So we did that, and it actually went fairly well. We had very little blood loss. You can see he has the liver remnant consisting of segment 4. You can see segment 4 there. So we got the and segment 2 and 3, which you can't see. And you can see the sutures that are placed into the left hepatic duct. And that was our anastomosis there. She had a relatively uncomplicated postoperative course. This was the histology, and it looked like we had clear margins on the histology. It was a moderately differentiated tumor, but this you can see the tumor on the left-hand side here, and you can see tumor in vein over there. So we discussed it at an MDT meeting after this, and she's at home at the moment. She's seen an oncologist about adjuvant therapy, but there isn't really good evidence for adjuvant therapy in this setting. So she's been closely followed up at the moment. It's developed a little bit of ascites, which you think is due to the portal hypertension, and that's starting to resolve now that she's been started on diuretics. That's the end of the case. I'm going to stop sharing. I'm not sure if there's any questions or comments. Okay, it doesn't look like it. Maybe, do you know if Brian is here?
Yeah, he's just setting up. Just give him 2 minutes and he'll be ready.
Okay. Anyone, I see John
Sorry.
Baton has a question. John, do you want to unmute? Or do you want to just...
Hi, yes. Sorry. Great talk. I'm just asking about the transplant criteria. I've also read some papers on this, and it's exactly like you said. Now, do you think we should then just start using the Toronto criteria in general?
So we had we had a meeting, like a consensus meeting with on liver transplantation in South Africa with us. So we're the one transplant group and the Joburg guys. So I can't remember if it was beginning, it was the end of last year. And I think we've agreed to use the UCSF criteria in both centers, but we are, you know, if a patient is outside of criteria and gets treated with local regional therapy or systemic therapy and has a good response and looks like they've got good tumor biology, I think both transplant centers would be happy to consider using the extended criteria in select circumstances. Yeah.
Yeah, perfect. Thank you.
Just waiting for Brian. I saw Wendy's Malini, yeah.
I had a question for Mohammed on his paper.
Yeah.
So he reported that he had patients who had systemic therapy who had some slightly better outcomes. I was just wondering, did any of them receive treatment for their primary, like a TACE, or was it just the sorafenib that they received?
Yeah. So the ones that received treatment, none of it was for their primary lesion. It was systemic therapies. So of the 15 of our 196 patients, only 15 of them had treatment, of which 13 had sorafenib, or 12 had sorafenib and 3 had doxorubicin.
I saw earlier on there was Neliswa and Wendy were on the meeting. I'm not sure if the hepatologists are still here. So I actually had a question. Are either of them here still? No. So I know I can think of, I think this is the third patient that we've had who's been treated for hepatitis C, who's developed an HCC. And I know at one stage there was a question about whether HCC incidence actually went up after you've eradicated hepatitis C. I was just wondering what the hepatologist's thoughts were on that, but it doesn't look like it. Yeah. Wait, Brian should join now. I'm sorry, guys. Sandy, I see you on the meeting. What did you think about that?
Sorry, Prof. Bernard, I didn't hear the question. What was the question again?
So after you've been treated like for hepatitis C, does the incidence of hepatocellular carcinoma go up?
After you've been treated for hepatitis C?
Yeah, yeah. Like in
Um,
the few years afterwards, is there a higher incidence of HCC, or does it go down, or is it just the same as before you were treated?
No, it actually reduces. What I think what you sort of allude to is that after the patient has been treated, during prior to treatment, they tend to develop the fibrosis, and then eventually cirrhosis. But when they're in the cirrhotic phase, you still have to, even though you've completed the treatment, you still have to survey them because they still have a chance of developing HCC, regardless of you having eradicated the HCC. This is just because of the background of cirrhosis that has developed. But otherwise, treating them before they even have developed cirrhosis, they're very or fibrosis. They're very good. The incidence of HCC in them is low. is reduced.
So if you treat a patient with Hep C and you do a FibroScan and they're not cirrhotic,
Yeah.
do you still have to watch them for HCC? Because my understanding is that HCC in patients with Hep C only occurs if there's cirrhosis.
Yes. So that's what I'm saying. Well, once if they're not cirrhotic and you've treated them and they're cleared, like they've achieved sustained virological response at 12 weeks, you actually discharge them from the clinic. But prior to treatment and you've done either the non-invasive or you've done a fibroscan and you see that they're actually having fibrosis, significant fibrosis, those are the guys that you follow up. Because you know that they still have a risk of progressing to either cirrhosis or even developing HCC.
Right.
But if they don't have any fibrosis, we actually discharge them. They're like cured and they don't have it. They're like any other person.
And how many of the patients you're treating for hepatitis C don't have fibrosis?
Quite a lot actually.
Is it?
Quite a lot of them don't have fibrosis.
Okay, cool.
Mm-hmm.
All right, Brian's joined us. Brian was actually operating on a HCC earlier today, which we might show you at some point.
Okay. Oh wow. Okay.
There was a patient who was not very well managed somewhere else. Actually quite interesting, but we'll show it at some point. Okay,
sure,
cool.
Sure.
Brian.
Okay, thanks, Mark. Sorry for keeping you waiting. The case I'm going to talk about is a 69-year-old male who had a relatively okay background, good performance status, no comorbidities. However, he had a previous history of significant alcohol use, which he had stopped by the time we were reviewing him. He presented with epigastric pain, and this was in an external facility about 6 months ago. And part of his workup included imaging that showed a left lateral section of the liver with a lesion. And we'll talk about the lesion on the imaging. He had no...
This is actually the guy you operated on today?
Yes, correct.
Oh, okay. So we are presenting him, okay.
Yes. So he has no history of chronic liver disease other than the alcohol use, and his examination was otherwise unremarkable. So he had normal LFTs and his Child-Pugh score was A6. He had a AFP of more than 20,000 at the first time of presentation. And they did a hepatitis screen, which included a surface antigen and a Hep B core total antibody, which was negative, and a hepatitis C, which was negative. So this was the first image, which was taken in an external facility. And this was what the treating team had used to inform their management. So I'll just take us through. There's obvious features of cirrhosis. So a shrunken or atrophied left hemiliver nodular. You can see the features of portal hypertension. So there's like large variceal portosystemic collaterals at the lesser omentum and perisplenic area, and can see the widening of the umbilical fissure. So the lesion to note is on the left lateral section, almost has an exophytic portion with a small intraparenchymal component. So on the different phases, the lesion was enhancing in a non-rim pattern on arterial phase and had washout. And together with the size and the cirrhotic liver, we scored it as a LIRAD 5 lesion. So the diagnosis was HCC, and the patient had features of portal hypertension, but has preserved liver function. And based on that initial assessment, his Barcelona score was at least early or intermediate based on the size. So it's greater than 3 centimeters. So that would not really fall in the early category. However, the lesion is in the periphery. So I'd still score it between early and intermediate. So I'll just pause there and ask what the audience think about what would they manage, how they manage this patient.
Hey, Brian, I might have missed that the hepatitis B was that?
It was negative.
Negative.
The core total antibody was negative and surface antigen.
Okay. Does
Okay,
anyone
so I'll-
anyone want to have a suggestion of what they would do now?
Okay, so I can just proceed to the next slide as you think about that. So this patient
Well,
was managed.
let me just say that I think so they went to do a resection, and I think a resection is the right thing to do because it's such an easy resection. You don't really get an easier liver resection than something that's on the lateral side of segment 2-3. So I would definitely consider resecting it. You're also not going to resect a very large volume of liver. The patient's got good liver function, although they do have some features of portal hypertension. But you know, if you're not doing a big liver resection, it's sort of a relative contraindication. So I think if the patient's fit, I think a resection is a good option. Yeah.
I agree to, and the fact that the patient was fit and the intent was curative, I think a resection was the best option for him. So in the external facility, an attempt at resection was made and it was abandoned because there was dense adhesions to the bowel. And you'll see on the later scans how close the tumor was to the stomach. And the patient was referred to oncology in that facility, and the oncology team started him on Folfox. He did 6 cycles of this, and thereafter he self-referred to our unit. Post-treatment, his AFP was 2,909. He was otherwise well, had not progressed in terms of distant disease or deteriorated in his performance status. So we scanned him in our facility. And so I'll just take us through the new scan. So same features of cirrhosis. You might argue there's larger variceal appearing portosystemic collaterals, particularly if you go lower in the retroperitoneal area and the mesenteric vessels. If you look at the left portal vein, it seems to be occluded with a blunt thrombus. However, the right portal vein is patent and the main trunk as well. And the other features are the lesion remains largely unchanged, has a large necrotic or a non-enhancing portion, and a small nodule that's enhancing at the lower aspect. You can see the close proximity to the stomach wall, and at some point the margin is lost at that point. So I'm sure we've just preempted it, but given the patient has a good performance status, preserved liver function, has a single large peripheral LIRADS 5 lesion with portal hypertension, and now the left portal vein thrombus that is bland on scans, would you have a different management strategy?
I mean, one of the things that's interesting is, you know, like I don't know if you found any evidence for treating an HCC with Folfox. I mean, I've never heard of that. And it's certainly very unconventional, and I'm not sure why that was done, but the alpha fetoprotein did come down, and the tumor did become more cystic.
So I just looked at a few retrospective reviews of patients who've been treated with conventional chemotherapeutic agents, and there've been quite a number of series, but the overlying or the overwhelming evidence is that there's a lot of resistance to these agents, and none of the guidelines support using the conventional chemotherapeutic agents. So I'm not sure if it's an access issue but the current guidelines do not support use of the conventional chemotherapeutic agents.
I must say it's not something that I think should be done, to be honest. Yeah.
So I don't have the resection photos. I think, Mark, you have them, but we took him in for a resection, and sure enough, that gastric margin was quite close, and we had to resect that segment, or rather do a wedge resection of that stomach wall, and oversewed that. And we took the lesion together with an anatomical margin of segment 2 and 3. So we don't have any post-op details at the moment, but that was our management strategy. Over to you, Mark.
Thanks, Brian. Are there any questions or comments? If not, I'm going
to. Mark, I have a
Yeah.
question.
Yes.
For a patient with this, a similar patient that Brian has presented, the
Yes.
lesion is quite big, it's more than 5 centimeters, and the patient already has cirrhosis, even though it's early, child A. What are the risks for developing decompensation post resection? Given that this lesion is quite big, so you have to remove quite a chunky part of the liver.
So, whenever we do a hepatectomy, we worry about that, even if the patient is not cirrhotic. So worry about post-hepatectomy liver failure. If you have a completely healthy liver, we would say that it's safe to resect probably 70%. And then, once people have had chemotherapy, the safe percentage goes down. And it's really quite crude, but in a patient who's cirrhotic, who's Child-Pugh A, the teaching is that it's safe to resect 50% of the liver volume. I would estimate that we resected probably about 20%, 25% of the liver volume in this patient. There are ways of better calculating it, and one of them is by doing a indocyanine green clearance test, ICG. And basically, we've done it. We had the machine very briefly, and what you do is basically it looks like a pulse oximeter. You stick it on the patient's finger, you inject the ICG, and it measures it, and you get a graph straight away of the clearance. And then the better the clearance, there's quite a well-validated model that will tell you that it's safe. It's probably safe to resect this amount of liver. So I think, if that is quite nice to have if you're going to do a big resection on someone with cirrhosis. This wasn't a very big resection, so I think it's, we would consider it safe. If that lesion was sitting in the middle of the right lobe of the liver and we had to remove the whole right lobe, and the right lobe was quite big, then you might find that wouldn't be possible, and then you'd have to start thinking about transplant rather.
Okay. Well, thanks.
All right. If that's it, I think I'm going to bring the meeting to an end. I'd like to thank everyone for joining, and thank you to the speakers. Thank you to iEcho University of New Mexico and the iEcho India team. Recordings of this will be available on the Gastro Foundation website. Thank you to the Gastro Foundation, and like I said, the presenters and the sponsors. Next week's meeting will be on patient blood management. Thanks, guys.